Good morning, everyone, and welcome. Today, we will deepen the functional walk protocol dedicated to the study of walking. Also, the walk protocol, like all the other functional protocols presented during our previous meetings, is part of the evaluation package offered by the BTS analysis system, which allows the clinician to globally evaluate the patient in order to draw up his own functional diagnosis. In defining the patient's clinical picture, which includes the identification of the main dysfunction and movement disorders, the residual potential and possible compensatory strategies, certainly the evaluation of walking plays a particular and important role. Thanks to the walk protocol, it's possible to verify if the muscular activity, mainly of the muscles of the lower limbs, follows the physiological behavior, and therefore it's possible to understand if the patient has a good coordination and symmetry of the movement, or if due to neurological or orthopedic disorders, the walking is compromised and altered in some of its phases. At the same time, the protocol is also part of the patient's follow-up, demonstrating with quantitative and objective data the benefit of the applied rehabilitation treatment. The test is very simple. After a short initial phase during which the patient stands still in orthostatic position, we ask the patient to walk as naturally as possible according to a straight path in order to perform at least 5 steps both with the right and the left limbs. At the end of the path, the patient must stop without making any rotation. From the technological point of view, the walk protocol requires the following wearable sensors of the BTS technology: 4 or 8 3mg electromyographic probes and the G sensor inertial sensor. The 3EMG probes, which obviously allows us to assess the behavior of the muscles, must be applied bilaterally to the muscles of the lower limbs. The choice of muscle setup, that is simply the muscles to be analyzed, can be free and decided by the clinician according to the patient's specific needs. But there are also 2 different versions of the protocol that require the use of a fixed muscle setup. With 4 channels, the analyzed muscles are tibialis anterior and medial gastrocnemius bilaterally. With 8 channels, in addition to the 2 previous muscles, the rectus femoris and the semitendinosus are added at the proximal level bilaterally. The fundamental rule to keep in mind during the application of the probes is that the electrodes have to be applied on the belly of the muscle parallel to the direction of the muscle fibers. During this webinar, we will focus on analyzing in detail the protocol with a fixed 4 channels setup. But all the information you will receive, especially regarding the reading part of the report, is always valid regardless of the muscle setup you decide to use. The inertial sensor G sensor, which allows instead to evaluate the kinematics of the walk, will be placed on the back at the level of the vertebra S1, S2, just below the line that connects the two dimples of Venus. Now, let's watch a video that shows the preparation of the patient and how to carry out the test. For the electrodes application on the tibialis anterior muscle, let's start from identifying the tibial crest and slightly move in lateral direction. If the patient is able to perform it, we ask him to go into dorsiflexion with the ankle, so as to identify the muscular belly well. The electrodes are placed parallel to the direction of the muscle fibers. With a light pressure, we make the electrodes adhere well to the skin. We repeat the same procedure on the left. I'd like to point out that palpation is always the best technique to identify the muscular belly. But there are different guidelines that help identify the point of application of the electrodes, starting from specific anatomical reference. In the case of the tibialis anterior, for example, we recommend to measure the distance between the head of the fibula and the lateral malleolus. Consider a proximal quarter and place the electrodes as shown frontally from the tibial crest. For the positioning of the electrodes on the medial gastrocnemius muscle, we ask the patient to go on the toes and place the electrodes exactly on the belly of the muscle in medial position. We repeat the same process also on the left. Finally, we place the G sensor. We identify the two dimples of Venus in connection with the posterior iliac spines. Compared to a line that joins them, the sensor must be placed below, so as to be totally integral with the pelvis. The belt should be tight. It's very important that the sensor is aligned with the axis of the spine and that the upper part of the sensor is at the same time parallel to the line connecting the two dimples. For the test, in each trial the gait must follow a straight path, and it's important that at the end of the path the patient stops without rotating. I also remind you that it's always necessary to give the patient the command to start walking only after having performed a short initial phase during which the patient stands still in orthostatic position. Okay. Once the test has been carried out through a quick and automatic computation of the acquired data, the test result is shown in a final report of clear and immediate reading, which returns the evaluation indexes of the symmetry and the quality of the gait cycle, the main temporal parameters of the gait cycle, the three-dimensional kinematics of the pelvis, and finally, the timing of muscle activation and the index of coactivation of agonist and antagonist muscles that allow us to evaluate the coordination of the patient. We now begin a more in-depth reading of all the contents of the report. The first page shows the symmetry and quality indexes of the gait cycle. As you can see, there is the symmetry index and the global symmetry index. The first index on which we must focus attention is the symmetry index, which is nothing more than simply the difference between the value expressed in terms of percentage of the stance phase of the right limb and that one of the left limb. The values of the phases are shown on the next page within the time parameters table, but for convenience, I report them here to make the explanation even clearer. As you can see, the difference between the value of the left and the right stance phases is exactly 2.2, which is the value of the index. Obviously, this difference is the same between the two swing phases, since both the sum of the stance and swing phase of the right limb and the sum of the stance and swing phase of the left limb are equal to 100. A good symmetry between the two limbs is maintained as long as this difference is less than 3.6, which is the highest standard deviation value considered normal for the swing phase. Ideally, if the symmetry index was 0, the right and the left stance phases are identical, as well as the two right and left swing phases. Once this difference is quantified, giving a different weight for the stance phase and the swing phase, the global symmetry index is obtained, which evaluates globally if the right limb and the left limb perform the respective gait cycle in a symmetrical way. If the global symmetry index is between 75 and 100, it indicates a high degree of symmetry. Let's now move on to the quality index of the gait cycle. Unlike the symmetry indexes that compare left and right limbs, the quality index is instead a characteristic of the single limb. In fact, the quality index evaluates the subject's ability to divide his right and left gait cycle correctly and in a balanced way. Ideally, the score of 100 is reached when the stance phase and the swing phase represent exactly 60% and 40% of the gait cycle, which are the values considered normal for each of the two phases. Let's now move on to temporal parameters. As we have just seen in the description of the indexes, any report information refers to the gait cycle, so we need to understand how to complete the gait cycle. The cycle starts with the contact of one foot with the ground and it ends with the next contact of the same foot. Inside the cycle, we distinguish the two main sub-phases, which are the stance phase and the swing phase. Within the stance phase, we further distinguish three other sub-phases that are the two phases of double support when both feet are in contact with the ground, and the central phase of a single support when the patient is loading on one limb. The one shown in the table here is the first double support phase. Therefore, taking into consideration, for example, the left limb, its first double support phase is that in which the left limb is in anterior position and it's about to begin the gait cycle, and the contralateral limb is in the rear position, still resting on the ground, and it's about to start detaching the foot to go into the swing phase. All the phases are expressed here in terms of percentage compared to the entire gait cycle that represents the 100%. But the same parameters are also reported in absolute terms of time or in seconds, because both information is important, as the patient, although it may have a change in its parameters in terms of seconds, he can still maintain a good distribution of the phases in terms of percentage. Let's now turn to the kinematics of the pelvis. In green on your left, you find the graphics that show the movement of the pelvis on the three different planes of the body, sagittal, frontal, and transversal, during the right gait cycle. Similarly, in red, on your right, you find the graphics that show the movement of the pelvis during the left gait cycle. Let's describe more in details a single graph. For example, that one relating to the movement of intra and extra rotation of the pelvis on the transversal plane. But the same information can be reported to the other graphs. On the horizontal axis, a full gait cycle is shown from 0 to 100%. And in this case, it's the right gait cycle because we are looking at the movement of the pelvis in green during the right cycle. The green dotted line that is more to your right side identifies the right foot off. Therefore, from 0 to the dotted line, we have the stance phase. And from the dotted line to 100%, we have the swing phase. By convention, a dotted line always identifies the detachment of the foot from the ground, while a continuous line identifies the strike of the foot with the ground. Within the stance phase of the right foot, we are also going to highlight this first red dotted line, which is the left foot off, and the continuous red line, which is the left foot strike. So from 0 to the red dotted line, we have the right first double support phase. From the red dotted line to the red continuous line, which is nothing more than the left swing phase, we have the single support phase on the right. And finally, from the red continuous line to the green dotted line, we have the right second double support phase, which is the left first double support phase, because from the red continuous line onwards, the left gait cycle is starting. The angle value in degrees is shown on the vertical axis. The horizontal zero line divides the graph into two parts, with positive values of the angle that conventionally identify an internal rotation movement, the negative values of the angle that instead identify an extra rotation movement. Since the pelvis is a single bone, in order to understand its intra or extra rotation movement, it's necessary to fix the attention on one precise landmark. I suggest to look at the movement described by the right anterior superior iliac spine when we evaluate the right gait cycle, and to look at the left anterior superior iliac spine when we evaluate the left gait cycle. The gray band represents the normal range, that is the correct movement that the pelvis should perform on the transversal plane. When the foot comes into contact with the ground, at the beginning of the cycle, the pelvis is intra-rotated. As soon as the foot begins to roll around the heel, and thanks to the propulsion coming from the contralateral foot that is going in the swing phase, the pelvis immediately performs an external rotation movement until it reaches the maximum position of extra rotation just before the foot off. During the swing phase, the pelvis again performs an internal rotation movement. Once we understand the normal pattern, it becomes automatic to evaluate how our patient is behaving. Okay. Let's now move on to assessing muscle activity. On the horizontal axis, as always, we have the gait cycle with all the different temporal events of the two feet. On the vertical axis, we have the value in millivolt of the muscle electric activity that is shown here in the form of envelope. The envelope is another way of representing the signal of muscle activity compared to the raw signal that you know. The envelope allows you to highlight the peaks of muscle activity. In this way, it's easier to verify if the muscle is turning on and turning off with a correct timing of activation, because the peak of activity should fall within these gray bands that represent the phases of the cycle in which the muscle must be active. In the white areas, the muscle should instead be turned off. In this case, we can see that at the beginning of the cycle, we have the activity of the tibialis anterior, which, as you know, must work in eccentric way to control the fall of the foot. During the single support phase, when the complete support of the single foot occurs, the tibialis anterior must switch off because the action of the gastrocnemius takes place, which initially works in eccentric way to control the forward rolling of the tibia on the foot, and immediately after, in concentric way to develop the propulsive force necessary to bring the foot off the ground and then the limb in flight. During the swing phase, the gastrocnemius has no more reason to work, and the tibialis anterior is again activated because it's necessary to move the ankle in dorsiflexion and the limb in swing phase, avoiding the foot touch the ground. Just below the graphs of the muscular activity, the index of muscle coactivation is reported. That allows to quantify the simultaneous activity of the agonist and antagonist muscles crossing the same joint. A coactivation index greater than its normal value may indicate an excessive co-contraction of the muscles and therefore a poor muscle coordination. I want to clarify that the coactivation index is calculated only if you are working with the 4 channels fixed muscle setup, which evaluates the tibialis anterior and the medial gastrocnemius muscles bilaterally, or with the 8 channels fixed setup with the addition of the other pair of antagonist muscles at the proximal level that are rectus femoris and semitendinosus bilaterally. In the event that the muscle setup is freely chosen by the user, the final clinical report is exactly the same as that illustrated now, except the calculation of the coactivation index, which is not executed. Well, what are the advantages of using the work protocol? Surely this type of evaluation allows us to highlight the limitations in working due to possible alterations and musculoskeletal disorders. Obviously, the instrumental evaluation must be integrated with the clinical experience, and it can provide quantitative and objective data to optimize the planning of therapeutic treatments. Finally, in the pre-post treatment evaluation, it's possible to quantify the benefit of the treatment performed on the patient. Okay, today we have concluded our 5 appointments dedicated to work protocol. I remind you not to miss the last appointment on 16th of May, during which we will present the static posture protocol dedicated to the postural assessment. Pay attention because the date has been rescheduled. I also remind you that our challenge is always valid. So if at the end of the series of webinars dedicated to the functional protocols, you have attended at least 3 webinars and you have correctly answered the simple questionnaires that we have proposed at the end of the webinar, so you will receive the certificate of participation released by BTS. I thank you for your attention and I look forward to the next appointment.